Our next case is an elderly patient on his late 70s. I know this gentleman for quite a few years already. Since a year ago, we treat his aneurysm in his belly with an endograft. A year later, the patient now presented with right foot blue toe syndrome. What it is his great toe in the right suddenly turned blue. Many times that means that the patient perhaps emboli or send a little plaque or fragment of a plaque into the branches that feed the toe, causing this discoloration. But because we wasn't sure about that, we did an ultrasound, and the ultrasound let us know that there's some potential blockages on the femoral artery on the right leg and also below the knee. So at this moment, we have an access in the in the left groin. We have a small sheath or a little sleeve into the common femoral artery in the left, and we introducing a catheter into the circulation. And in the right side of the screen, we can see the endograft located in the iliac aneurysm. Now, since the patient has some renal impairment, that means some insufficiency on the kidney function, we don't want to use iodine contrast because it may difficult his renal clearance of the function of the kidney. In those kind of scenarios, we use CO2. It will protect the renal function and it will avoid having some problem with the kidneys. All right, so we have the catheter right in the aorta, and we're going to inject the CO2, and that will give us a very nice picture of the flow through. And you can see both iliacs. Those are the two arteries that come out from the aorta at the bottom. We're going to use that image as a mapping to introduce the wire into the right side. So this catheter in particular, it has this kind of horseshoe configuration. It will allow us to push the wire through the right side. All right, so we got the wire across the stent, and we'll try to move the catheter down to get a better picture of the right lower extremity. And again, we're using CO2 to minimize contrast damage into the kidneys. All right, so far, the femoral circulation looks fine there. We're going to move down some more. So we can see the flow is kind of sluggish, and the reason is that the heart rate of this patient is on the low side, and it's because the medication that he's using. However, I don't see flow coming down through the femoral artery. All right, we're going to inject some more, and this is at level of the knee. We just want to see where the artery starts showing up. Through that collateral, we can see now that the femoral artery is filling right above the knee. So from this point down, appear to be open. So the main problem of this patient is that he blocked off the circulation from the groin to the lower part of the thigh. We have the wire now at the beginning of the femoral artery. We can appreciate that the wire make a loop there because it's unable to cross the blockage by itself. One of the techniques that we use to cross those complete blockages is to use a catheter to support the wire so we can push the wire through the complete blockage. In many instances, we see what we call a stenosis, which is a partial stricture of the artery. But in this particular case, we have a complete shutdown of the circulation through the femoral artery. So I'm going very slow because the tightness of the blockage, you can see the little dot of the end of the catheter moving forward. And I know by the previous angiogram that there's flow just getting close to the edge of the bone right there. Because I feel the resistance to advance the catheter, what I will do is get a balloon, start dilating the channel of the blockage, and hopefully I can move further down with less restriction. This is a very long balloon. It goes from the tip of the catheter up to this point where my fingers are. It's almost 20 centimeters long. It's tapered at the end, so that allows to navigate through the plaque. For sure, we will feel some resistance on moving this device down, but we're going to try to dilate it little by little until we get to the lower portion of the femoral artery. As you can see, we use the wire as a guiding tool. Everything goes over the wire because we know that the wire is in the center of the plaque. So here we go, the balloon reaching down to that point. If you show me the other end of the balloon, I will pull and uncover by moving the sheath or the sleeve back again. And then we are ready for the first dilatation of the artery. This is maybe a big artery. It's between 6 and 7 millimeters. You can see the dye coming up to 12, please. You can see the waist in some areas. If you go down right there, very tight blockage there. All right, down. All right, follow the wire. Okay, I think we passed the area of blockage. And we have the catheter below the knee. So this is a picture. So what we're seeing here is the circulation just below the knee. It's called popliteal, the first segment. Then this artery divided in 3 branches. This is pretty much the standard anatomy for most of the people. I think he has missing one of them, the one that goes into the right side of the screen is gone, but he has a good middle branch and the outside branch. They're good caliber, they're good. Many ulcers in the foot, they don't heal just because the flow that is coming from above is not good enough. It doesn't contain the amount of oxygen needed to create the wound healing process. So we come in with a straight wire, try to get it into the middle branch. Here we go. I'm planning on using a 5 millimeter balloon. And then after that, we're going to repeat the 6 millimeter at the top. And then after that, we might need to use a stent to maintain the lumen or support the flow all the way down. So we're coming in with a 5 millimeter balloon. We're going to use this one at some point right here and above. Here we go. Let's go up to 12. Yeah. So the waist and the balloon will tell us where the blockages are. So it's still that segment, very tight, but the balloon fills up nicely below that area. That's it's telling us that the artery below the bone, the border of the bone to the knee is good. Okay, coming back, take the balloon out. 6 millimeter balloon. Coming back. Okay, from here up. Good. 30 seconds on this one. Go ahead. Go ahead. 14. Yeah, we can see the irregularities on the balloon. Still that spot down. All right, so this is going to be the first angiogram after the balloon angioplasty of the entire femoral artery. So I'm shooting from the groin down. We're going to divide this in 2 views. The first one is this one over here. You can see there's flow now through the femoral, although it looks irregular. And the next one is going to be the bottom of the artery right there. In spite of being irregular, the flow is fast. You can see there's dye moving fast into the lower portion, which is telling us that there's a good opening somewhere there. So I think the decision here is to deploy the stent. That's going to be the only way to contain the plaque in that side. The decision process of using a stent versus just do angioplasty obeys basically on the cosmetic result of the angiogram. Sometimes we use the IVUS to come out with that decision as well, but here it's very obvious to me that the angiogram doesn't look quite good. You see there's still a lot of plaque causing constriction in some areas, like the one in the middle right there is very tight still. It looks very irregular along the length of the artery itself, so I know that angioplasty alone, it won't last as a therapy. You have to do something else. Occasionally we use the laser, or we use devices like atherectomy device. Those are kind of cutting devices. But the problem with this case is that in some areas we are very close to the wall of the artery, and in some areas we are in the middle of the core of the plaque. If you are too close to the surface of the artery, you may end up cutting too close, and then you finish with a perforation. So the decision is important of what device you want to use. I think here we have to stay simple with the stent to get adequate result. So this is a self-expanding stent. That means it's like a spring. Once we open up the membrane that is covering the stent, it will deploy by itself. In many instances, we use a stent that are supported by balloon. That means the balloon prop open the stent, but this one is a self-expandable. Once I uncover the stent itself, you will see it will start coming open like a coil right there at the bottom. Maybe we can magnify the view here, Robin, so everybody can see that. Right there, there's some little dark marks at the end that tell us what the end of a stent is. So I'm gonna continue pulling back. And what I'm doing is uncovering the stent that has been constrained inside the tubing of the delivery system. So it's coming very nice. Actually, it's opening very good there. Part of my stent is still inside the sheath, so I'm going to move the sheath back. And continue the deployment. So we're going back to the lower portion right there. Now, if we look at the stent, let's go back and check on the stent to see if there's any area that is still partially deployed. Right there, where we saw the waist in the angiogram is still not completely open, but for the most part, the stent is well deployed, well open. We're going to use a balloon to further dilate that stent. It's something that we do in most of the self-expandable stent. Now, the other question is above the stent. I think there's another segment of the artery. Let's look at that now. So we're going to check on that first portion of the artery, right there. Yeah, still kind of irregular right there at the beginning. We need to use another stent there. So we can use the 6mm one. This time it doesn't have to be that long. Perhaps 80mm length will do it. All right, so we have approximately half a centimeter overlap with the previous stent. I'm going to start opening the bottom of the stent right there. And we want to reach right up to the beginning of the femoral artery. As I mentioned before, the side branch that we're looking at in the outside is the profunda artery. And we don't want the stent coming across the beginning of that vessel. So the stent is being deployed. Now we are in a position that we can use a balloon and further dilate the two stents. All right, we started distal first. That means at the lower portion of a stent.
Distal stent.
Okay. Let's get it out. So we're going to 14 atmospheres. Yeah, you can tell the area is very stubborn. It's okay, down. All right, we're going for the final picture here. So let's start at the top. So the first picture is the upper thigh. All right, next one. Here we go. Let's do one below the knee also. Good. I think in summary, this patient presented with a change in color of the toe, mostly in the right great toe. We were lucky to go across the blockage all the way from the top to the bottom and do some angioplasty. That kind of rechannel the flow through, and then we end up deploying the stent. That will immediately change the color of the toe as well as the perfusion, which is the circulation of the calf. And hopefully the claudication is going to disappear and the patient will be able to save his toe. Thanks for your attention.